In this video, we'll be doing a cataract surgery and Hydrus implantation. This is a step-by-step video to show how to go about the implantation during a routine cataract surgery. So we place two incisions, one that's around 4 o'clock hours from the implantation site of the microstent. We inject some lidocaine in the anterior chamber. We place our viscoelastic in a soft shell technique with a viscodispersive first and then our viscoadaptive in the nasal angle. And then I like placing some visco-dispersive on the surface of the eye. Either is good enough to give proper visualization. Then we place the injector in the eye, place the gonio prism over the eye. We like to increase the magnification to give a good view of the trabecular meshwork. And then we give about 15 to 20 degrees angulation of the injector. We incise trabecular meshwork about 100 microns till we lose that metallic sheen at the tip. We start advancing the microstent. Once the first window is in, we level off to be parallel to the iris plane, and then we continue the advancement of the implant by advancing the roller wheel. We see here all three of the windows nicely positioned in the Schlemm's canal. Then we could advance the implant just a little bit more so that the neck is about halfway in and we have a nice position of the inlet of the device in the anterior chamber. Then we create our main incision and we do our capsulotomy, our hydrodissection, hydrodelineation using a Chang cannula, and we go about doing the cataract surgery using a quick chop technique. So when the Hydrus implant is placed, it can be a pretty quick procedure, doesn't add too much time to the surgery. Once we've removed all the cataract and we're going to come out of the eye, we want to make sure that we keep the eye pressurized to avoid any heme reflux. So we inject through our side port some balanced salt solution and keep the eye formed. And then once we do the irrigation aspiration, same thing. Once we're done, we're going to do the same technique of keeping the eye pressurized. We're seeing here the area of blanching, which we're going to highlight. And we inject some viscoelastic in the anterior chamber and the capsular bag. So then we place our lens in the eye, we remove all the viscoelastic with irrigation aspiration, and again, once we're coming out, keeping the AC formed. And then once we're hydring our incisions, we see some blanching here of the collector channels, collector plexus, possibly showing some improvement in distal outflow. And then once we pressurize the eye, we try to leave it in the low 20s to avoid any heme reflux. Thanks for tuning in.